Hello everybody, I'm Dr. Rosie Bronnett and I'm the Quality Improvement Clinical Advisor for NASAL. Today we're going to have a look at some data to think about how NASAL can help you understand the local position about recognition of dying in your hospital and how that data might help you understand what quality improvement work is needed. So we're going to go through how to access the data and what it might mean using some example data. So just a reminder that if you access the NASAL portal, that has information including the link to access the data improvement tool as you scroll down. It also has a link to our quality improvement pages and a reminder here of our driver diagram, as well as links to our upcoming events. So we're going to now show about logging into the data and improvement tool. As you press this button, usually you come to a login page, but to protect my data, we've already logged in. It takes you to the data and improvement tool page, which has the dashboard view as well as the overview here. We're going to start off looking at the overview. And this is just a reminder that our 10 primary drivers, including the one that we're focusing on today, which is recognition of dying, are down the side and you can navigate the information related to them. So first, we're going to look at this example submissions data related to the different audit elements from NASAL about recognising dying to help understand your local picture. So it might be, for example, that you do this in response to a question about whether you are good as an organisation at explaining to families that their relatives are likely to die during that admission, or when you're responding to complaints, or to try and work out exactly where to focus improvement efforts. So in this case, you start off with looking at whether the deaths were expected or unexpected in those audited by NASAL. So the national picture is that around 80% of people who had their notes reviewed as part of NASAL, it was expected that they would die. And in this example submission, it's slightly above that. However, when you go down to the next section, you find that in this example submission data, when it wasn't recognised that somebody would die, there was a lower proportion of people that had discussions about being sick enough to die that admission, despite the fact that on review of the notes afterwards, it was not a surprise to the auditor that they had died because of risk factors in their health. And you can use some of the other views to help understand where you fit in the national picture by using the Explore view here. So this shows where the example submission fits in. So for example, here it does show quite clearly that things are in the tail of discussions at this point. You can then look at a time series, which will become progressively more helpful as we have more different quarters, and see that things have slightly improved in the third submission quarter. Now, what is really important to note in this, as we go back to the overview page, is the number of patients that are in this example submission. Now, because we know from the previous question that there were quite a high proportion of people that were recognised as dying, this example submission only has between 11 and 20 patients that were not recognised as dying. So it's much more vulnerable to variations on an individual patient basis. So I would suggest that at the moment this is an area that this organisation may wish to keep an eye on, but perhaps it needs more information, a higher number of submissions in this area to be able to reliably decide whether this is a priority for quality improvement focus or not, and enable the data to stabilise. There is then information, if you wish, about the day of death and the time of day of death, but we're not going to focus on that today. We then come to the series of time relating to recognition of dying, admission to death, and the average time from recognition of dying to death. So just starting with the middle one, you can see that in this example submission, there was a shorter time of 14.4 days compared to 16.1 days from admission to death. Now, going back to their other data, this organisation had a shorter time between admission and recognising dying, which perhaps reflects that people were dying more quickly in their organisation. But interestingly, they have a slightly longer time between recognition of dying to death. And so it may be that this organisation, this example submission, recognises dying a little bit earlier than some other organisations. So this will be something to keep an eye on, and it may be an indicator that looking at those people who come through the front door is an area to focus on, because it may be that there are issues relating to how sick people come into hospital and questions about whether their care could or couldn't be managed in a different place. So looking at another separate audit element, we have the staff reported measure, and we're asking whether staff who are confident recognising whether a patient will be imminently dying within hours to days. And there's a fair amount of agreement in the local submission results compared to the national average. So in both of these, the staff that completed this were quite confident, and so it may be that this is just helpful to keep an eye on when you're thinking, for example, about whether that matches up to patient experience, or if you have any problems that you identify when you're looking at the review. For example, if staff are very confident, but actually that isn't what you see in practice, it may be that you need to look at an initiative to address that. And here we're looking at results from the quality survey, where we're asking whether a member of staff explained to the person that they were likely to die in the next few days. And the answers here require you to look at the codes a bit more carefully, because they don't always correspond in the order that I think maybe we would intuitively put them together. But it suggests that around 36% nationally and 38% in this example submission did think that there was an appropriate discussion about recognition of dying with the person who was going to die. There is, as is in keeping with information we've had before, a fairly high number of around 30% of people who were too unwell to have any discussion, but around 10 to 15% of people don't really know whether that happened, and there may be many different reasons for that. So I think this information that I have looked at with this example submission suggests that this example organisation is recognising dying. There may be some questions about whether people come into hospital who are more unwell than on the national average and die sooner, but that may be something that warrants further analysis. And also looking at this bit where people may not be recognised as dying, but are there opportunities earlier on to have conversations that you might be sick enough to die? That is worth a look once there is more data. But the information from this recognition of dying can also be helpful for you to look at other aspects of the nasal data. So for example, if we move on still in the overview section into the individualized management of symptoms section, then you can see that there are some sort of more stark differences here in the national sample versus this example submissions information. So here you're seeing that there is a quite significant gap between daily reviews being documented of an assessment of someone's symptoms. And you may, this example organisation may want to see whether that's different, whether somebody was recognised as dying or not. And this is when you might want to use the filters section. So here you can choose the types of death, and then here you can select an expected death where it was recognised that they were going to die, or an unexpected death where it was not a surprise on retrospective review that somebody died, but the exact timing was not the same, not known. So here you can see it takes a little bit of time to load, but if anything, this makes it more marked that there's a difference here in this organisation compared to the national average. And so if I were feeding back to the end of life care lead or anyone else within the organisation, I would say that this example submissions data about recognition of dying suggests that there may be some focus needed to improve the quality of actions and reviews once somebody is recognised as dying, and there is a bigger gap in that than the recognition of dying itself compared to the national average. So just going back to the recognition of dying sections, you can see that some of them take a little bit of time to load, and we know that that will hopefully be fixed in the next few months as the completion of all the work to improve this tool is completed. It's important that you remember to take off your filter so that you're back looking at all of your data, not just your category 1 and 2 data. I'm just going to refresh the screen there. And just as a reminder that you can save the information here, I'm not going to do that today, but you can either extract the picture itself or the data, and then that can be helpful to directly put this into a report rather than having to rely on screenshots. And then just as a reminder, there is also a dashboard view where things are grouped together. Now on this view, it's really important that you select your submission, otherwise the data itself doesn't really make sense because it looks at cumulative time. And so here it reflects again some of those trends that we were talking about, where there is a difference in terms of the times between admission and recognition of dying, but actually quite a lot of commonality in the time between the recognition of dying and death. So this is a summary view, and as you can see, you can use the different view buttons down here to fit it to the page and adjust the size to help it fit so that it is easier for you to review. And a bit like the overview section, there are these tabs along the top. So depending on how you want to present your data, how visual people want and how much detail, those different overview and dashboard views can be really helpful. So in summary, really, the nasal data can really help you to drill down in terms of identifying a quality improvement project by helping you to understand the problem in detail, maybe find a metric that you would like to track to see if it changes following an intervention, and help work out which may be your priority areas.